So I am a neuropsychiatrist. So I'm a child psychiatrist by training, although I did quite a lot of pediatric neurology and pediatrics before I moved into child psychiatry. And at the Evelina, we I guess don't have a focus oncology kind of service. I used to work at Birmingham Children's Hospital, where there was a very large pediatric oncology service with brain tumors. So I guess some of that comes from the experience there. But actually, I think within the Evelina, in terms of us being one of the largest neuroscience centers in the country, just thinking about the experience around acquired brain injury, epilepsy, kind of broader neurodisability, I think a lot of that is very pertinent to not just this talk, but actually I think probably the session and definitely what I was hearing in that previous session also before lunch. So this is a very broad bird's eye view around thinking about mental health. I've taken quite a lot of slides with lots of data, but if you want to ask me about that or kind of catch me after the session, I'm more than happy to speak to you about the stats. So in terms of the current literature, so the accumulated research that we have around mental health difficulties, and I have called this mental health difficulties because actually in the literature, it is difficult to do a search with that term. And I think if I was to compare that to other areas of neurodisability, so cerebral palsy, for example, or epilepsy, it does seem quite distinct, actually, within neuro-oncology, that the terms that get often used are things like psychological distress, psychological problems, even kind of collapsing that within quality of life kind of measures. So it is difficult to try and pull the data out from the literature, but this is my analysis of it. So the aspects that underlie mental health difficulties are these two areas. So this is where like a health-related quality of life measure that measures your experience of the treatment, the ongoing kind of rehab, if there was rehab, beyond that. That's where some of that source of mental health difficulties come from. And then the other, where there's lots of data, which both Naomi and I think Charlotte will definitely talk about in their talks, is around the data around cognitive impacts. And again, that's both from a brain tumor kind of perspective, the primary pathology, so the tumor itself, but also the treatment that we might use. So it's a brain tumor, so kind of like, positioning of it, the length of time it's been there, how long it's not been detected, and then the treatment aspects, and then how they kind of impact cognition, but also the experience, the person's experience of having cancer and having their treatment for it. I think these factors at the bottom are factors that as a psychiatrist, I think I almost intuitively think about all the time. So we often talk about this biopsychosocial model as a psychiatrist or anyone trained in mental health. And I do find that, again, it is quite distinctly missing within the literature. Not that there hasn't been. So there have been some very detailed cohort studies in survivors for childhood cancer, and they have looked at some of these factors. But actually, no one's really tried to pull it together to try and see it from the lens of mental health. So psychological factors like self-identity, self-esteem and confidence, for example, family factors in terms of thinking about that transactional aspects around, say, the stress that a family member might be going through, and then how that transacts onto the child themselves, and then environmental factors, which, I think from the stories that we heard this morning, they did a much better job in trying to describe how schools, how kind of leisure activities, how your social kind of environment, how those are important factors also to one's mental health. And then in terms of conditions, or I guess more, like I said, because the literature refers to difficulties or differences more often, this is my analysis of where the literature is. So there is some stuff around neurodevelopmental difficulties. So this would be things that we would associate with, say, learning or autism or ADHD or tics even. But actually, it's very lend heavily on attention. And ADHD gets mentioned, and often when I read a description of what's being described, say, within a case series, it's quite clear to me as a psychiatrist that actually they're describing a child with ADHD, but actually that diagnosis hasn't actually come up as part of the description. So lots of kind of focus on attention. And there are different types of attention aspects here, kind of thing. And again, maybe Shao might go through that in her talk. There's a lot around mood, so depression, for example, and anxiety. And then more recently, I would say within the last 5 or 6 years, there's definitely been a fairly uptick around recognition of trauma. And that's not just that description of post-traumatic stress disorder that some of you might recognize, PTSD, but also the concept of developmental trauma. So the trauma that comes when a young child has interruptions to the relationships that they have with prominent carers. And then mood and anxiety comes up again, which I think is quite distinct from the mood and anxiety of the experience of having a brain tumor and its treatment, which I would say is being described as what's being observed, but actually I think that there is an overlap with how, say for example, some of the stories I've heard today, undetected learning difficulties or kind of subtle aspects around how you're processing information or needing to pace yourself or sensory issues that might come up. So I think that, again, there is a set of mood and anxiety issues and behavioral difficulties that are being described within the research literature that actually is quite distinct from, I think, the depression and anxiety that's being described, mainly in the adult survivor kind of data around the experience of treatment or the experience of having a brain tumor. And then if you remember, I talked about these other factors, and actually when we think about difficulties as a mental health professional, we're always trying to think about what then is the impact, how much is that impairing these areas of functioning. So it's important that we're thinking about the impact along your individual psychological aspects, your family, that wider kind of system. So, in terms of relationships with friends, with school, things like that. This is the only data slide I'm going to put up, but I think this is probably going to come up in the next talk, isn't it, Manya? Yeah, you're going to refer to this, I think? Yeah. Okay, but I just wanted to highlight that in this fantastic study that many of the authors are here in the audience. They did look at what they term neurobehavioral kind of deficits, and this was defined as people who needed supported special needs schooling, attention problems, and behavioral problems. And you'll notice that in this particular group of children and of tumors that we're going to be discussing in this session, there's a high co-occurrence. I was going to put this up also just to highlight that actually this doesn't actually align with how we might measure mental health difficulties actually in lots of other childhood conditions. So actually, I think this is a call to the professionals and the academics in the audience that actually we need to start thinking together with mental health kind of researchers how we try and align that together, because then that really helps us, isn't it, advance some of the aims that has really been stated today. And there's an increased kind of prevalence that seems to be associated with metabolic dysfunction and radiotherapy. So going back to this broad kind of overview, I was just going to mention a couple of comments about each of these areas. So I think in terms of the neurodevelopmental difficulties, I think it is really under-recognized. So I think that actually my own personal experience, and not only when I was working within an oncology center in Birmingham, but I think right now, when I'm then seeing children quite far down their journey, where they've maybe gone through some kind of period of acute kind of treatment, rehab, they've been struggling in school a bit, kind of thing. People maybe have been talking about things that might resemble ADHD or might resemble a learning difficulty. And actually, there is a real delay in that being characterized. So I think it is a big need. I think it is beyond attention. And I think has already been commented earlier this morning in the other session before lunch, that actually sometimes the thing that makes it difficult to spot, say from a school's professional's perspective, is that it's not the full-blown syndrome. So it's a little bit of ADHD and a little bit of social communication difficulties that we might associate with autism, or some aspects of learning, but then actually in other areas that doesn't seem to be as impaired. A mention about mood, anxiety, and trauma disorders. So I think in this area, broadly, just in thinking about children's health within a children's hospital or in a secondary or tertiary care kind of setting, there's been a real advance in terms of thinking about the experience of children coming into hospital. So even planning before they come in, instead of just thinking in that old style way of, let's get the play therapist in, when they're in the ward already. So I think that actually this does dovetail with some of the efforts that are much more broadly in terms of understanding psychological health within a pediatric kind of setting. So hopefully we're going to see the benefits from that might not just come from looking at the specific cohort of children. I think behavioral difficulties, as a psychiatrist, is just a lazy way of not trying to understand what that child's trying to communicate. So to me, I'm always really interested in what's being communicated here. That's not an end of having problem behaviors. For almost all children, it represents something else. And then I've stuck up things like somnolence and mutism because I think it's just the sin of clinicians and academics that we kind of go with the zebras, isn't it? I think someone mentioned that this morning, isn't it? I think so. All the rare stuff is actually quite well described in the child psychiatry literature, but actually this is rare stuff, I think, So stuff to do with cerebellar kind of mutism and posterior fossa, I can probably wax lyrical a bit more about that kind of thing. But actually, I think that those other circles are the things that in my experience, are actually the main things that really are impacting children's lives and their functioning in the very long term. Right, so in the title, there was something about medication. I can't go through all these medicines with you, but it was just to say these are the three broad areas that I think come up in my experience in this broader group of brain tumors. And it is relevant. So if I was to say compare that across pediatric oncology, I think that obviously we are seeing higher rates of neuropsychiatric conditions within children with brain tumors. And I think it's already been commented this morning about the kind of experience of methylphenidate, and I'm not sure whether that young man's here. Is he here? I think, Helen, you're... yeah, I think Yusuf made a much better point than I can make, which is that it's not just about the medicine. It's about how you think about the situation and that time of life for that young person and understanding how that medicine actually works and working together with that young person and their family to think about when's the best time, what's the dose escalation around that. But there is a place for it. I think there's also a place for thinking about some of the other medicines that we have for ADHD, for example, that are licensed, but actually don't seem to have kind of got into the literature in this area. Antidepressants, I think just to kind of mention that we just need to be careful. Often what I find with antidepressants is not so much about that people are not asking me to prescribe it, but are not thinking about the biological effects of it. So these are medicines that can affect kind of liver processing of other medicines, and these are children that often will be on other agents. So we've got to think about those types of effects. And then lastly, in that kind of other medication kind of group, if a child's got epilepsy and they're on anesthesia medicines, actually, I think the role of a neuropsychiatrist or a liaison psychiatrist is also trying to think about, it's not just about adding something that might seem really familiar to a psychiatrist. It's about how we optimize some of the medicines like anesthesia medicines, which actually have mood stabilization properties within that also. Last slide is just to say that I totally recognize the service complexities. I chaired two kind of scientific committees for some rare genetic conditions, as in a charity like this. And I know that questions that often come up whenever I give talks like this is just about services. So let me just address, which is that we know that community camp services are very stretched in this country. We know that there are long waiting lists. We've heard some really clear stories throughout today already around difficulties with access. What I would say is that sometimes it's about coordination rather than just more resource, which I think was a point that was made in the session before lunch. And then the other thing to say is that there is a wider mental health kind of workforce. So I clearly think that there's a role for someone like myself, but I think that there's also roles for people who deliver psychological therapies, who think about supportive kind of treatments, and it's kind of working together in that multidisciplinary way that we know is really helpful in mental health, and not just, I guess, a medical approach to things. I'll end off there.
Well done. Thank you, Ashley.